Hello everyone, now we continue our discussion to crack down the big case scenarios. So this is what we do. Okay, now this case, you see somebody with joint pain, and you see right upper quadrant abdominal pain, small arthralgia like in the hand arthralgia, fatigue, hepatomegaly, dilated condyle duct, pale skin, and in a young patient. What do you think? This could be autoimmune hepatitis, so you check anti-smooth muscle antibody, okay? Now, the second case is that they usually give you, what do you think if there is a 33-year-old woman that had a gastric bypass surgery, and after the gastric bypass, she developed nausea, vomiting, early satiety over the last 2 weeks has been constant. What do you think this could be caused by? This caused by something called stomal stenosis, like which means the small intestine that looped around that bypassed the stomach. This could have a stenosis and could cause that symptoms, that kind of obstruction. Okay. Now, the other case, what if we tell you there's a patient with Barrett's esophagus and high-grade dysplasia? What would you do? This patient, you do endoscopic ablation. And that brings us to the discussion of Barrett's esophagus. If there is high-grade dysplasia confirmed by pathologist, you need ablation. What if it's low-grade dysplasia confirmed by pathologist? What do? You do PPI and surveillance endoscopy in 6 to 12 months, or you can do endoscopic eradication as well. Okay, so you can one or two options. Okay, what if there is no dysplasia? Then you just do PPI and surveillance endoscopy in 3 to 5 years. Okay. Now you can ask me what causes Barrett's esophagus. Usually when there's GERD symptoms, like heartburn can cause that Barrett's esophagus, which is like the esophagus transformed to something malignant. But not in everybody. That's people who have high risk factors, like for example, age above 650, white people like a higher risk, hiatal hernia as well, obesity, or increased waist circumference, or there's current or formal tobacco use, or there is first degree relative with Barrett esophagus or some esophageal adenocarcinoma. Okay, so that's why you do screening endoscopy for these patients. If it's fine, then nothing to worry about. If there's some esophageal metaplasia or columnar lined epithelia with esophageal metaplasia, then you have the pathology read the biopsy and just to see if there's a dysplasia or not. Okay, now this case is interesting. Somebody had appendectomy, right? So they have increased risk for what? Small bowel obstruction. So they came in with small bowel obstruction like abdominal pain or and tender abdomen, empty rectal vault, crampy abdominal pain. There is a small bowel obstruction. So what would you do for this patient? You do upright chest x-ray and abdominal x-ray just to see where the obstruction is going. Okay, now if you see somebody with abdominal distension, there is positive fluid shift, and there is right costal margin, and the right costal margin, AST/ALT is elevated, albumin like 4.3, there's ascites is like 2.4, so there's portal hypertension, right? So, and then they give you a bunch of options. What causes portal hypertension? And this question, they bring you all the others doesn't cause portal hypertension. There's only one thing causes portal hypertension, and they didn't bring the liver cirrhosis in the thing. So this one you choose hepatic vein thrombosis, okay, or what we call Budd-Chiari syndrome. Now you could ask me what causes that. Could be caused by polycythemia vera, malignancy, pregnancy, oral contraceptive pill, hypercoagulable state, idiopathic, so anything that increases coagulation. How does it present? There are two versions of it. Acute, that happen in women, causes right upper quadrant pain, hepatomegaly, jaundice, ascites, variceal bleed, encephalopathy. This is the acute version. And there is subacute, like chronic version of it. It could be asymptomatic for weeks to months, and then you develop abdominal pain, ascites, hepatomegaly, lower extremity edema, cirrhosis, jaundice, encephalopathy least common, but it causes lower extremity edema and cirrhosis. Okay, this is very common. And how do you diagnose it? You diagnose it by doing like Doppler liver ultrasound or CT scan. You can also do magnetic resonance angiography showing decreased hepatic venous flow. And you'll see serum ascites albumin gradient will be high. What is the gold standard that confirm 100%? You do venography. Venography will show venous occlusion and spider web pattern of collaterals. Okay. If you still don't know if it's thrombosis or not after venography and after Doppler ultrasound, after CT scan, after MRI angiography, you still don't know what's going on, you do biopsy. Okay. This is the story of hepatic vein thrombosis. Okay, now this patient, 22-year-old, found unconscious next to a bottle of bleach, so you just do GI endoscopy just to see if there is anything going on inside, if there is erosive ingestion, to grade the severity. Sometimes just to see what to do, you know. Steroid is not recommended in this case, just do EGD. Okay, now you have somebody who transglutaminase positive, diagnosed with celiac disease. What do? You need bone scan, okay? Why? Because it's one of the risk factors for osteoporosis, because it can cause osteomalacia, osteoporosis in adult and children, causes rickets, okay? Celiac disease. So celiac disease, because if you can't absorb food, this is gonna damage almost everything. Like so, the skin causes dermatitis herpetiformis, atrophic gastritis because of vitamin deficiency, cause vitamin D deficiency, so cause the parathyroid hormone to go up, cause iron deficiency, cause a neuropathy, depression, and anxiety because you're not absorbing enough nutrients. And the symptoms, it causes diarrhea, weight loss, abdominal pain, flatulence, okay? And the light manifestation can be ulcerative jejunitis, enteropathy associated T-cell lymphoma. These are the complications of celiac disease. So celiac is very high yield for the test, so they test a lot about it. Somebody came in with high liver function test and some depigmentation, okay? And they ask you what is the most likely diagnosis, okay? So now you see that you need to know how to work up elevated liver enzyme like AST, ALT elevated, okay? So if there is elevated AST, ALT, what do? You want to rule out the most common liver diseases. What are the most common diseases? Hepatitis is a big one, B and C. Alcohol, you want to check alcohol blood level or history. Consider fatty liver disease as well as a common one. Drug-induced hepatitis, if somebody taking drugs that are causing that. And hemochromatosis. So if all of those are negative, what would you do? You determine the likely source, okay? So if the source is hepatic, then you evaluate for autoimmune hepatitis, Wilson disease, alpha-1 antitrypsin deficiency, then you do liver biopsy. But if the source is not hepatic, then it could be other things like muscle disorder, thyroid disease, celiac disease, and adrenal insufficiency. So there are many things that can cause elevated liver enzymes. So one of them is celiac disease. So you gotta be careful with that. If all of them that's likely and they give you celiac disease, then that's probably the right answer. Alright, now you see someone have diarrhea for 6 months, so you check transglutaminase is positive. What would you do? You want to do EGD with duodenal biopsy to confirm the diagnosis if this is actually celiac disease or not. Okay. What other things you see in celiac disease? Other than elevated tissue transglutaminase, you also see anti-endomysial antibodies. Okay, and then the biopsy you can see increased intraepithelial lymphocyte and flattened villi. Okay. Cutaneous biopsy for dermatitis herpetiformis is also diagnostic as well. There's dermatitis herpetiformis, you don't need to biopsy there. Going just to biopsy the skin, which is interesting. Alright, now there's a patient you keep treating them with thyroid therapy, has hypothyroidism, but it's not responding to the thyroid hormone. Why is that? Patient resistant to thyroid. So you take history more, there's a bloating, fatigue, bloating, large thyroid. What do you test? You test for anti-transglutaminase antibody, because celiac disease prevent absorption of thyroid hormone, and that could be the reason. So you want to know what's causing this refractory hypothyroidism. Okay, now another disease, another celiac disease, very interesting. So you see very high yield. Somebody who's 35 woman, he came in with 3-year history of celiac disease. Now she came in with fatigue, abdominal pain, and diarrhea over 3 months. Okay, you check the stool is dark stool, ESR is high. So why is that? So somebody had celiac disease for 3 years. Now you have fever, abdominal pain, diarrhea. You know, the ESR. What is going on here? This could be something called intestinal lymphoma. This is one of the complications of celiac disease. So now that brings us to the discussion, what are the complications of celiac disease? Celiac disease could be if somebody have poor dietary compliance, or this causes symptom recurrence, okay? And then you will have high antibody titer, and so you want to do careful dietary history, see what they're actually eating, what they're not eating, okay? And there is one that's called refractory sprue, refractory celiac, which is because there are 2 types. Type 1, they don't respond to the gluten-free diet for 12 months, like right off the bat. Type 2, they have initial response, but then symptom return despite dietary adherence. This is usually poor prognosis, could progress to lymphoma, like in this case. And treatment, you need to give glucocorticoid. Just treat it like this is autoimmune, so you need to suppress the immune response as much as possible. There's the third complications, which is the intestinal lymphoma and ulcerative jejunal ileitis. Okay, this is why does that happen? Because there is a lot of T cell population will gather in the small intestine, and could cause abdominal pain, B symptoms, GI bleed, like in this patient. Abdominal pain, B symptoms like fever, fatigue, and a dark stool like GI bleed. And then could present with intestinal obstruction and perforation, and it does not respond to steroid. Okay. What other causes that can coexist with the celiac disease? Like it can be associated with lactose intolerance, irritable bowel syndrome, pancreatic insufficiency, microscopic colitis, and small intestinal bacterial overgrowth. And that's our summary for celiac disease. Now you talk. Another question they ask you. See a lot of questions for celiac. They tell you, okay, how do you vaccinate somebody with celiac? What do you do? This is how you for the test. What do you do? How do you vaccinate celiac disease patients? You do pneumococcal vaccine. So for celiac disease, how do you manage it? First, you do gluten-free diet and you educate. First, you do dietary counseling with dietitian, monitor lifelong adherence to gluten-free diet, and then you access, like, there's a group, connect them with a group that have the same celiac disease, and just like they take tips from each other how to eat. And then there is a nutritional deficiency that's the problem in celiac disease, like iron, calcium, vitamin D, folic acid. These are the most common nutritional deficiency. So you want to monitor those. And you want to prevent bone loss. How do you prevent bone loss? So you do DEXA scan at the diagnosis and repeat DEXA scan 1 year later if osteopenia present. Why? Because celiac increases the risk of osteopenia and osteoporosis. Third thing, vaccination. You want to vaccinate, do pneumococcal vaccinations because their immune is lower. So you want to vaccinate them for pneumococcal. And there is dermatitis herpetiformis. How do you treat that? You do dapsone in addition to gluten-free diet. Okay, that's how you treat celiac disease. Now, this case it's an interesting case. You see 81-year-old with acute cholecystitis. What do? You do cholecystectomy or percutaneous cholecystostomy. Percutaneous cholecystostomy is better for this patient. And they usually give you elevated alkaline phosphatase, lipase, fever, hypotension, He's a pretty sick guy, so not to take him for surgery. Just do percutaneous cholecystostomy, drain the inflammation, and then you can do cholecystectomy later. Okay, this is our gallbladder question. Okay, Now this question is also interesting. Like somebody who have a chronic disease who had ileal resection. What do you do after ileal resection? What medication usually helpful for ileal resections? You give cholestyramine. How does cholestyramine bind the bile salt? Okay, and it helps like for bile salt malabsorption from ileal resection. Okay. Because people with ileal resection, they will have B12 deficiency, and a lot of the fats and fat soluble vitamin, they stay in the tract and causes a lot of symptoms, flatulence and some fatty stool. So the bile acid goes and cholestyramine goes in there, binds to the fat, and that's how it helps reduce the symptoms. And usually they also need vitamin B12 and fat soluble vitamins. Okay, vitamin B12s and fat soluble vitamins. Okay. Now we have this patient that have weakness, 58-year-old man coming in with weakness, abdominal distension, swelling, high AST/ALT, and then 20% neutrophil and acidic fluid, and then you do the ascites protein, acidic fluid analysis. Protein shows 1.8. Okay, what does that tell you? So if it's 1.8, this is what you need to know. Acidic protein, if it's 1.8, this is either cirrhosis or nephrotic. If it's more than 2.8, it's less than 2.5. More than 2.5, this is liver heart failure. So it's less than 2.1, 2.5, and there's AST/ALT, either nephrotic or cirrhosis. The only one that causes high AST/ALT is cirrhosis. So what you want to do, you want to do upper EGD. Why? To look for varices. This is liver cirrhosis, so you really want to do varices in portal hypertension. This is portal hypertension. So now you could ask me, what are the guidelines for variceal prophylaxis in portal hypertension? So the guidelines is different, okay? So if there is cirrhosis without varices, then beta blocker is not recommended. You just repeat EGD every 2 to 3 years, and you repeat yearly if decompensated or there's alcohol abuse. What if this is the first one, okay? Okay, there are 4 types. This first one, no varices. Second one, there is a small non-bleeding varices. Here still beta blocker is not recommended. You just do repeat EGD every 1 to 2 years in compensated disease, and you repeat EGD yearly in decompensated or there's alcohol use. Okay, so the frequency is just like instead of 2 to 3 years if there's no varices, here 1 to 2 years because there's varices. Now where there is medium large varices, then in this case you will do beta blockers and you repeat EGD yearly. Okay, or you can do endoscopic variceal ligation. This is fine too. What if there is a small varices with red whale sign or decompensated cirrhosis? What would you do? You do beta blockers and repeat EGD yearly. Okay. Alright, now we got this case. Somebody with diarrhea and PCR positive for C. diff. Okay, what would you treat it with? You treat with fidaxomicin. This is the new drug on the block, and because they want you to know about the changes that happen in the management of C. diff. So how do you treat like somebody recurrent C. diff? This one is first recurrence. Okay, first recurrence. So if somebody have the treatment of recurrent C. diff, like if there's first recurrence, the preferred is fidaxomicin, as in this case. Alternative, you can do oral vancomycin in tapered or pulse regimen, and you can consider having adjunctive intravenous bezlotuximab. Okay, you can do that, but usually people don't do that. It's a pretty expensive drug. This is the first recurrence. How about the second or subsequent recurrence? This is still the preferred fidaxomicin, or you can do vancomycin tapered and pulse regimen. Alternative options, you can do oral vancomycin followed by rifaximin. Okay, and you can do the bezlotuximab adjunct therapy as well. And then in this patient, you can consider suppressive therapy if they have multiple C. diff, like long-term oral vancomycin. You can do fecal microbiota transplant for the third or subsequent recurrences. Okay. especially for high risk patients like age more than 65, immunocompromised, or severe C. diff infection. It's, you know, it's good to add long-term suppressive therapy, and you can add the adjunct therapy like intravenous bezlotuximab, which targets specifically the C. diff toxin B, target it and block it, you know. So it can be helpful for these kind of patients. Alright, now you have somebody with the diarrhea, abdominal pain, and hypotension. Okay, abdominal pain, diarrhea, and hypotension. And then there is 8 centimeter dilation of the ascending colon and mucosal thickening. Okay, what's the best next step? So this is severe C. diff colitis. What would you do? This is severe C. diff colitis. How do you manage it? The way you want to manage this severe C. diff colitis, you give high dose oral vancomycin plus IV metronidazole and urgent surgical evaluation. Okay, so this is how the severe fulminant C. diff colitis present. There's hypotension, shock, ileus or megacolon, you know. This is what you want to do. And if it doesn't respond to that, to oral vancomycin, IV metronidazole, you do fecal microbiota transplant and surgical evaluation, you know. This is the fulminant one, okay? Now there are 2 other types of C. diff as well, severe and non-severe. Severe if it's leukocyte more than 15,000, creatinine more than 1.5. Okay? If just symptoms, they don't have leukocytosis, this is just like classic symptom, perfused watery diarrhea, abdominal pain, no leukocytosis, this is non-severe. Both, we treat them with the same oral fidaxomicin or oral vancomycin. Okay. Now, you have somebody with abdominal pain, and then you see red blood in bowel movement and tender left lower quadrant. What would you do? And there is leukocytosis. What would you do? You do CT abdomen pelvis with contrast. Okay. Because there's a red blood in with bowel movement and tender left lower quadrant abdominal pain, and there's decreased bowel sound, leukocytosis. This suspect colonic ischemia. Okay. Okay, it's kind of interesting and tricky. So you suspect colonic ischemia, so you do CT abdomen and pelvis with contrast. Okay, so now there are different types of ischemia. There's colonic ischemia and there's a small bowel ischemia, mesenteric ischemia. There are 2 different things. Colonic ischemia, usually there's no clear precipitant, usually somebody older than 60, and then usually present with left-sided pain with abdominal tenderness, side abdominal, lower quadrant abdominal pain with tenderness, and patient doesn't look severely ill. You can see bloody diarrhea early, and you diagnose with CT scan with contrast and colonoscopy. Okay. How about small bowel mesenteric ischemia? Small bowel, usually due to preceding event, like there's atrial fibrillation, variable age, there's severe pain without significant abdominal tenderness early in course, and patients usually appear severely ill, and hematochezia is late complications, unlike the colonic, like early, because it's closer to the colon, the rectum. Small bowel, like hematochezia, is early, late complications. And you diagnose with magnetic resonance angiography or angiography. But with the colonic ischemia, you just do CT with contrast and colonoscopy. So it's a beautiful, interesting, very different, 2 different distinct diseases that you need to be aware of. Okay. Now you have somebody with fatigue, abdominal pain, diarrhea, ulcerative colitis, you see on colonoscopy. They tell you, okay, when do you do colonoscopy? You do colonoscopy at 8 years, okay? And then 1 to 3 years afterward. And that brings us, when do you do colon cancer screening? For ulcerative colitis, we talked about it. How about if someone have relative with colon cancer? You do either at age 40 or 10 years prior to the age of diagnosis, and then every 5 years. How about regular patients, just at age 45, and you repeat every 10 years? Or you can do like the FIT every year, or FIT DNA every 1 to 3 years, or CT colonography every 5 years, or FlexSig every 5 years. Okay. Or you can do FlexSig every 10 years with annual FIT as well. Yeah, it's pretty nitty. Interesting. There's so many options, you know. Now you have somebody like you failed to visualize visualization of colonic mucosa incomplete. Whenever they say that the incomplete visualization of the colonic mucosa, you do colonoscopy within 1 year. Just repeat it. You know, there's like 3 small adenomatous polyp as well that they give you. Okay, this is a question. So you want to repeat colonoscopy within a year. Now, somebody who have colorectal cancer and dad has cancer at age 55, what do? You just do screening at age 40, like the screening guidelines that we just talked about. Now you have somebody who have weight loss, constipation, and rectal mass adenocarcinoma invading the tumor muscularis propria to the perirectal tissue. What would you do? You do chemoradiations followed by surgery and chemo. Okay, this is like how to treat locally advanced rectal cancer. Usually do pre-op chemotherapy, because this is going to reduce the cancer and try to preserve as much tissue as possible. And then you do surgery, cut it out, and then you do post-operative chemotherapy as well. Okay, this is for advanced rectal cancer. Okay, how about somebody who has non-obstructing mass in the left colon, and there is a 2.5 centimeter left colonic lesion to invade the serosa and enlarge lymph nodes, and there's irregular borders seen within the right lobe of the liver. So this is metastatic colon cancer, okay, to the liver. How do you manage it? You manage it by hemicolectomy and resection of liver masses followed by chemotherapy. That brings us to discussion of how do you manage metastatic colon to the liver. So you ask yourself, is there an extensive unresectable extrahepatic disease by CT, MRI? If there is there an involvement of the hepatic artery or major bile duct or portal vein? Is there extensive liver metastasis, like more than 70%, more than 6 segments involving 3 hepatic vein? Is there any inadequate liver reserve for resection? If there is any of that, like, which means the tumor is like invading big part of the liver, then you do initial chemotherapy, then hemicolectomy with surgical resection of the liver disease. Just like the rectal cancer, try to compress the tumor as much as possible to preserve as much tissue as possible, and then you take it out. But if there isn't any of that, there's the tumor like in the liver, not invading arteries, not invading veins, there's a good amount of liver. If you take this out, you do hemicolectomy, surgical resection of liver disease, and then chemotherapy. Okay, that's kind of the management. It's pretty interesting. Now, what do you manage if you see 71-year-old have delayed motility in the proximal colon? If you delayed motility in the proximal colon, you do bulk forming laxative would be very helpful, because such as methylcellulose or ancilium, these are bulk forming laxative. Now, so what are your criteria? Now you know you want talking about constipation. It's a very important high yield. So what is the ROM3 criteria for functional constipation? You want to have symptoms more than 3 months, with full criteria within more than 3 months. What are the criteria? You want more than 2 present for more than 25% of bowel movement. So more than 2. Either straining with defecation, lumpy or hard stool, incomplete evacuation, sensation of anorectal obstruction, manual maneuver required for defecation like digital evacuation, less than 3 bowel movements per week, loose stools rare unless laxatives are used, okay, and does not meet the criteria for irritable bowel syndrome. Okay, so now another case, we're talking about constipation, opioid induced constipation, refractory, nothing helped. You give methyl naltrexone, should check the trick. Somebody have 3 months constipation, what would you treat it with? You treat with checking TSH. Okay, you check TSH. Okay, somebody diabetic have persistent diarrhea and soft to watery bowel movement. So diabetic with persistent diarrhea, soft to watery bowel movement, bloating, flatulence, decreased vibration sensation. Why is that? There is like, so you know there's diarrhea and vitamin B12 deficiency and diabetes. If you see these 3 things, this is bacterial, small intestinal bacterial overgrowth, and this can be caused by diabetes. So we talked about uh, diarrhea and constipation, right? So diarrhea, what is the pathophysiologic mechanism of diabetic diarrhea? Usually there's autonomic neuropathy, causes abnormal small bowel and colonic motility, bacterial overgrowth, and anorectal dysfunction. Okay, and can be associated with factors like diabetic food, like sorbitol or concurrent celiac pro. Okay, so this is for bacterial diarrhea. Now, you see somebody with abdominal pain for 2 days and left lower quadrant. You do CT, showed sigmoid wall thickening. So this is diverticulitis. How do you manage this diverticulitis? The patient doesn't seem too bad. Vitals are stable. What do? You do oral antibiotics followed by outpatient follow-up. Diverticulitis you can treat as an outpatient. So how do you manage diverticulitis? What antibiotics orally? You do give Cipro and Flagyl or amoxiclav. Okay, this is uncomplicated diverticulitis without significant comorbidities. What if there's uncomplicated diverticulitis with significant comorbidities, like the patient's sick, having a lot of risk for complications, or there's complicated diverticulitis, like unstable vital signs, you give IV antibiotics like beta-lactam with beta-lactamase inhibitor, like Zosyn, you can do, that's a good one. Or you can do Rucefin and Flagyl, this works well. Or you can do ciprofloxacin and Flagyl as well. This works as well for the diarrhea. Okay. Now I want to discuss. So we discussed the diverticulitis, we discussed the diarrhea, we discussed the constipation, and we talked about constipation is important. You want to know, like for the constipation, there are things that I want to talk about it more. So if somebody have more than 3 months of less than 3 bowel movement per week, this is defined as constipation, okay? And more than 25% of bowel movement requires straining, this is constipation. What are the alarm features? Alarm features: if there is anemia, hematochezia, positive FOBT, if there is weight loss, if there is family history of colon cancer or inflammatory bowel disease, if there is prominent unexplained change in bowel habits. How do you manage it? You manage it: medication change or fiber or lifestyle adjustment. Further evaluation, you do endoscopy of more than one alarm symptoms. Okay, and for review what we talked about, now we review what we talked about. Like we talked about diarrhea, we talked about constipation, we talked about how colon cancer metastasizes to the liver, what we do. We talked about rectal cancer, how do you manage it. We talked about colonoscopy, when do you do that, when you do screening, when do you do it for inflammatory bowel disease like ulcerative colitis, how do you manage C. difficile. We talked about when do you do upper EGD for liver cirrhosis. We talked about liver cirrhosis, we talked about ileal resection, we do cholestyramine, and acalculous cholecystitis, pneumococcal vaccine. Talked about a lot about celiac, like necrosing intestinal lymphoma, pneumococcal vaccine, antitissue transglutaminase, EGD duodenal biopsy, celiac disease with could cause high liver function test, bone scan for celiac disease. We talked about erosive esophagitis, if somebody suicidal with a bleach or so, trying to hurt themselves. We talked about abdominal bowel obstruction, Barrett's esophagus, when do you do endoscopy at that. We talked about stomach stenosis, anti-small muscle antibody, hepatitis, and how to treat it, autoimmune hepatitis, treated with steroid, and how do you manage ascites with high-dose spironolactone, low-dose Lasix. And that concludes our discussion for this session, and thank you for listening.